Good evening, everyone. On behalf of IPL Community Core Group and IPL Kolkata chapter, I'm Showman the host. Welcome you all to today's webinar. Today's moderator is Dietitian Anindita Mandal ma'am. So I will request Anindita ma'am to introduce our today's speaker, Dr. Anuradha Mukherjee. So just let me share the screen. I think the screen is shared, right? Can you please confirm the screen is shared?
Yes, sir.
Yes. Over to Anindita ma'am.
Hello. Hello. Good evening, everyone. This is Anindita, an executive committee member of IPEN Kolkata chapter. First of all, I would like to thanks to our IPEN chapter because IPEN is the platform where we can come and just share our knowledge. And for that reasons, we are here to discuss in different topics. So today, our topic is very interesting. And it is, the thing is that it's just like a chronic disorder. The patients are very pathetic situations and it's a chronic, they cannot heal from that completely. So it's a chronic stomach disorder where food moves very slowly from the digestive tract. And despite there being no physical blockage. So it's a stomach paralysis, you can call, and this called is the gastroparesis. And our topic is the gut glucose axis, dietary management in gastroparesis, and nutritional strategies for better metabolic health. Many reasons are there to having that gastroparesis. Mostly diabetes is the reason. Some are idiopathic, some are after operation surgical problems also going on, and then the gastroparesis happen. Post-viral infection is one of the reasons, and sometimes Parkinsonism is also the reasons for the gastroparesis. We will discuss in detail. I would like to get questions after our sessions. So first, I can introduce our eminent speaker, Anuradha Mukherjee. So don't want to waste our time so with a brief, large introductions. So Anuradha Mukherjee, Dr. Anuradha Mukherjee, she's an associate professor and HOD of Dietetics and Nutrition Department, NIHS and NSHM Knowledge Campus, Durgapur. She did her graduations and post-graduations from Kolkata University. Post-graduation's diploma in food safety and quality management from Jadavpur University also in 2011. Done her PhD from NIT Durgapur. She is the chief coordinator in ICAI. Her academic experience is almost 2 decades. She is a practitioner and speaker also. She has authored numerous journals. She got Best Academic Mentor Award for significant achievement, the Best Teacher Awards in 2023 by Times of India, Executive Committee member of NSI of Kolkata chapter also. So she is the founder of Nutritious You Diet Clinic, where the mantra is healthy eating and right living. Over to you, Anuradha. We don't want to waste our time, so we'll discuss after questions after her sessions. So let's start Anuradha's sessions. Over to you, Anuradha.
So first of all, I'm spellbound to get such a wonderful August introduction by our very own and favorite Anindita ma'am. And thanks are torn to Shomendo sir and the entire team. I'm really indebted for giving me this opportunity, and I'm wholehearted thanks and gratitude to everyone of IPEN, including Ipshita madam and Shudeshna madam. So I hope that I'll be able to do a bit of justice related to the present topic. And I would also like to share my August audience that the topic was also intended and well searched and researched by our very own Shomendra sir. So thanks to him and for all the efforts finally which made us come together in the platform as we are all here. So without further ado, let me just share my screen. And let me just know from you all so that I'm like whether I'm okay with the screen sharing. So is my screen visible to all?
Yeah.
Okay.
Yeah, perfectly all right, Anuradha.
Okay, thank you. So the topic as vividly described by Anindita ma'am, it's like a very insightful topic which I have got today. So the gut glucose connection, dietary management in gastroparesis, and nutritional strategies for better metabolic health. Now, individual of this, this connects of this particular title is a storytelling. So, I mean, it's so, connected. So the second brain, the gut, is connected to the glucose, and how, I mean, each and every story inbuilt is actually related to the hyper or the hypo and the related troubles as in a part of gastroparesis. Let us just get into the in-depth version. So, as detailed by Anindita ma'am, I'm basically an academician. I've been into academics for last 20 years almost, and slow but steady doing something as a part of my practice. I'm actually an academician and heading the Department of Dietetics and Nutrition in NSHM Knowledge Campus, Durgapur. But apart, as passionately, I'm doing some of the case studies, and one or two I have picked up, especially for today's session. And let me just delve into those particular case studies and give you a background of this present title. So the name, as it is said, Mrs. Ria Sen, which I have appropriately changed, putting it a name which I could remember as a part being a celebrity. So Mrs. Ria Sen, 34 years old, and she is professionally a school teacher, living with type 1 diabetes since age 15. So she's having a long-standing diabetes, and at present she is complaining. While she came to my clinic, she complained of bloating, sense of fullness, abdominal distension, taking a bite or two, she is full. And the most difficult part is that she is unstable with a lot of nausea, puking difficulties, and her glycemic control is also very, very unpredictable. So sometimes she's showing off hypo, sometimes hyper, that random sugar, the PP and the fasting sugars are all taking twists and turns. So not really into a positive glycemic control. And patient, when she came to me, she just said that I feel full after just a few bites. So that is, annoying. And my stomach swells after meals. And sometimes I even vomit food hours later. So this is actually a concern. Now, the clinical red flags here actually is the long-standing diabetes, because she is into type 1, as we can all understand, and erratic glycemic control, even though she is into insulin. But as we all know, the type 1 indicates insulin only, so erratic, but still then she was actually into an erratic glycemic control, and symptoms were all there, which is actually worsening day by day, and even to most appropriately after large meals. That means the macros, what all she's trying to take, which usually we all take for lunch, dinner, breakfast, often at times, every time she's actually facing the challenges of puking. And so naturally, she is, under a psychological difficulty, that she's having a fear associated with eating. And of course, there is another difficulty. She's constantly losing on weight. And of course, she's having very poor appetite. So as I could understand that it could be anything related to, like any of the GRD or acid reflux, or it could be anything related to the gut, of course, where metabolism is at stake. But I requested her to visit a gastroenterologist, who is also a very good friend of mine. So she has visited Dr. Prerna, and who's a very eminent gastroenterologist here in Durgapur. And after that, I came to know that she was asked to do upper GI endoscopy, different blood investigations as related to her case, and also this gastric emptying scintigraphy. So the findings was nothing but no structural obstruction, but there is, of course, the delayed gastric emptying. So ultimately, this final diagnosis came out as it is nothing but it's a secondary to type 1 diabetes. So it's like gastroparesis, which is actually turning out to be as a secondary to type 1 diabetes. So this is case 1. And also I have another case, which is case 2. And here I have Mrs. Neha Kapoor, who is actually a 42-year-old lady working in corporate and very known to me. And she was actually suffering from obesity, and her was a type 2 diabetes patient. She was a type 2 diabetic patient, and she has recently started with a semaglutide, and for 3 months, as per her history. And initially, she was benefited by showing, some signs of weight reduction, which is pretty good for her, because she really wanted to look better and reduce some weight. So she has rightly could do it with semaglutide. And of course, appetite suppression was her real problem. But of course, she was maintaining a better glycemic control in these days. And why did it happen suddenly? Because we all know that semaglutide shows gastric emptying to increase satiety. And in some individuals also, it is like excessive gastric slowing, food retention, nausea and bloating, delayed digestion, and of course, gastroparesis cannot be ruled out as a symptom. So these are, the mechanism to do with the semaglutide. And I'm sure and certain that all of you as practitioners, you must be knowing about this as a side effects to semaglutide. Now, GLP-1 RA. So now this is, like this patient. The worry part, the most annoying part was a patient coming and complaining that I can barely finish half a sandwich without feeling sick. So the point lies, case 1 and case 2, they're more or less coming up with the same complaint. So there lies the problem. And the clinical, as usual, the investigations were asked to do the same one. I mean, the upper GI endoscopy, ultrasound, gastric emptying scintigraphy. So all this which are also being associated with gastroparesis and its diagnosis. So the clinical concern here was symptoms were worsening after dose escalation of the semaglutide, because, over enthusiasm actually led her to, without titration led her to get into another, the doses were escalated. And then actually she came to me in between, where the weight was actually reducing well, and she was quite well maintaining her glycemic control, but at the same time worry was her appetite suppression. So here also the diagnosis after the investigations were seen to have this gastroparesis, and which is likely to be associated with semaglutide use. Now, both the cases, we are, once we compare both the cases, the similarity lies where, as the topic rightly says, that the gut and the glucose connection. So the diabetes, one for type 1 and the other one type 2, resulting in semaglutide therapy. And that actually the symptoms were more or less the same. And the mechanism was, once it is a long time, so it is autonomic neuropathy, and getting into the vagus nerve, some defective working of vagus nerve. And finally here, case 2, the mechanism lies with the common mechanism as taken up by semaglutide, and the nutrition concern was the same thing for case 1. We see the glycemic instability still existing because it's very unpredictable behavior she was actually showing. And here the case 2, she hardly was in a condition to eat. The first one was also not eating well. So both were actually nutritionally, they were malnourished. So, and they were very, very unwell in a condition. So treatment finally, as hand in hand, we always decide that the dietitians should always be related with the doctors. So I, along with our gastroenterologist, we decided that, of course, I am no one to deal with the drugs. So the optimization, titration were done by madam. And of course, the diet was given in such a way that finally she was a bit stable. Both the cases were stable and she at least could continue. But of course, major difficulties were okay, but still they are having minor difficulties. It's not absolutely, absolutely erased off. So let me go further and delve into the cases and the final of our story. Now, gastroparesis in diabetes, the stomach glucose connection. So what happens actually in both the cases also, we have seen that in diabetes care, what becomes our concern? We often focus on insulin and carbohydrates. So these are the two, parameters which we actually concentrate. But what if the stomach itself is a key regulator of glucose variability? So this session would actually explore gastroparesis, an underdiagnosed condition where delayed gastric emptying creates unpredictable glucose patterns, particularly in patients.
Sorry, ma'am. Unfortunately, the screen goes away. You have to again share the screen.
You're not allowed to share your screen. It's showing me.
No, it is allowed. Unfortunately,
I really don't know why. What has happened? I'm suddenly being told that I'm not allowed to share.
No. You just do.
Achha, let me see.
Is there parameters there? So screen sharing.
Achha, is it okay now? Am I okay? You can see
me.
Yes.
Okay, fine.
Continue, Anuradha.
Should I go
Continue.
back this way or should
Yeah,
I get into a full screen?
Full screen.
Now is it okay?
yeah.
Okay.
That's fine.
Okay.
You just continue.
Thank you so much. Okay, so here this session explores gastroparesis, where an undiagnosed condition where we actually understand why the delayed gastric emptying creates unpredictable glucose patterns, and particularly in patients with long-standing diabetes or type 1 diabetes. So here we have the learning objectives, very specific, and I have tried to, understand what exactly should be our learning objectives, like understanding the mechanism, and then we need to know the symptoms, because this gastroparesis is quite familiar with and similar to the other metabolic diseases creeping in. It can just H pylori infection, or maybe GRD, or maybe heartburn. So it keeps on having the repetition in the symptoms actually. So we need to understand the mechanism and underlying pathophysiology of the delayed gastric emptying before we actually come into a diagnosis. And clinical nutrition strategies we need to understand as a learning objective, that we need to have evidence-based dietary interventions that address both the gastroparesis symptoms and glucose control simultaneously. And then OPD application, because all of us are actually practicing in some way or the other. So we need to contribute accordingly to our OPD, and and adapting to individual patient needs, because one diet fits all cannot happen. So we need to customize and tailor fit the diet which actually we plan. And the clinical part here is, this is a dietitian sensitive condition. We need to understand that, of course, it is something to do with medicines. A lot of, psychological counseling is also very, very important part of this gastroparesis. But of course, a dietitian, it is a very, very important and crucial role of a dietitian, where actually nutrition plays a very important primary therapeutic role, and dietary recommendations directly influence both the symptom burden and glucose stability. So we have to be very careful. Now, I think Anindita ma'am has already defined what is gastroparesis. So I just, redefine it once more with her clue only. So this is nothing but delayed stomach emptying without any physical blockage. So this is very dangerous, because in every scintigraphy or, gastric emptying condition, we finally gastric emptying study or breath test, we actually find out that there is no obstruction, but yet the delay is there in terms of food getting down to from the stomach to the intestine, small intestine. And food remains in the stomach for longer time than normal, and this entirely disrupt the expected digestion timeline. So risk factors already she discussed, that gender, diabetes, long-term diabetes rather, even type 2 diabetes can cause, as we have seen in the case. So it can also cause this gastroparesis, and long-term drugs. Lot of drugs also create not in semaglutide always, but there are other drugs also, like calcium chain blockers, which can create this gastroparesis while used for a long time. And autoimmune diseases like type 1 diabetes, and also other diseases like Hashimoto and others, that can also create this disease. And of course, neurological conditions like Parkinsonism, as madam also mentioned. So these can also create gastroparesis and can be risky for gastroparesis. It's not always certain that we will have, but it could be a factor. And idiopathic, it can be just like that. We end up in a gastroparesis just with diabetes. So that is nothing but no clue to it, but we end up in gastroparesis. So that is being idiopathic. So the symptoms, as we have already been mentioning since the first slide, that early satiety. So patient, there is a feeling of fullness just after a few bites, and the patient has a constant nausea, vomiting, and where most of the time the digested food comes out, and the patient is bloated, abdominal discomfort is long-term persisting with the abdominal discomfort. And this once the patient is diabetic, because now today we are not doing gastroparesis in general, but we are linking up with the long-term effect of diabetes. So here also, for gastroparesis, along with diabetes, the unpredictable glucose patterns is one of a very common symptom ruling over. Now, this is the core mechanism. So normally what happens once we eat a food, there is a sphincter, that means nothing but this gullet, and that we always remember that this gullet pathway where we get a sphincter and the food comes from the esophagus and we get into the stomach, and from the stomach the food gets into a mechanism of peristalsis by all the driven mechanism of the muscles, and there is a rhythm generated, and finally the food is getting down by indication through a vagus nerve, and which is a very very important part. And once it is getting a signal, it gets down through a pyloric sphincters through the small intestine, and then so on. It is in this way the absorption takes place, and finally this mechanism continues, and we have a definite digestive time for individual food, the liquid, the solid, the semi-solid, and this is the way the food is actually gets into mastication, and finally it is being digested, absorbed, and further into the metabolism. And finally this opposite to it, not really opposite, but here what happens with gastroparesis, the vagus nerve is damaged. It could be due to surgery, it could be due to long-standing autoimmune disease like type 1 diabetes. So the vagus nerve is actually this is actually, it's a part of this neuropathy, and the vagus nerve is damaged, and for that reason it is not functioning well. So there's no signal given to it. So the mobility is actually hampered, and the food is stored in the stomach for pretty long time, creating a lot of difficulty. The drugs are being taken, insulin is acting on no food condition, and then finally it is creating a hypo, and finally when it is actually getting into this emptying, and then the food is the insulin is almost vanished off, and then finally it is creating an hyper with more of the sugar spiking up in the blood. So this general mechanism is actually ruling over for gastroparesis. And finally, the clinical note here, most common in patients with long-standing diabetes, especially when glycemic control has been poor over many years. And here we just see to it that uncontrolled diabetes leading to gastroparesis, high blood sugar. I'm just reading out the diagram which I have created. Now, uncontrolled diabetes, persistently elevated blood glucose level, and this creates to a chronic hyperglycemia. Now, this already I have discussed that long-term high blood sugar actually damages the vagus nerve, and that is a very normal this autonomic neuropathy is created, and from there the damage to the vagus nerve and the stomach nerves, and finally it is impaired nerve signaling. So the signaling gets hayward, and finally the stomach muscle contractions, impaired mobility actually happens, and that delays the entire stomach in emptying the food contents. And all this finally cumulatively it ends up getting into a symptomatic gastroparesis, when nausea, vomiting, early satiety, bloating, abdominal pain, poor blood sugar control results. So the flow diagram would be uncontrolled diabetes, nerve damage, impaired stomach motility, and finally ending up to gastroparesis. And then the epidemiology, that underdiagnosed reality. So it's like very poor compliance, as we always already been discussing. Type 1 versus type 2, more prevalent in type 1 diabetes due to longer disease duration and higher rates of diabetic neuropathy. And type 2 patients with poor glycemic control are increasingly also affected. But if you go by the epidemiological outreach, then of course the numbers are less as compared to type 1. Now, prevalence in Indian context is likely rising due to widespread suboptimal glycemic control trends and limited access to gastric emptying studies, meaning that many cases remain undetected in routine practice because there is a confusion with the symptoms. That is the main reason of getting into unrecognized or undiagnosed. So normal gastric emptying physiology, as I was discussing, that every gastric emptying for individual type of food like liquid phase, solid phase, it is actually varying. So it's not the same for everyone. Now, again, the liquid to liquid, it varies depending on the density, and solid also varies depending on the consistency of that particular food. So liquid exists rapidly through the pylorus within 10 to 15 minutes. Usually, it is not it's not a mandate, but it is seen like that. and solids undergo a time of around 2 to 4 hours. Now, here the glucose gatekeeper, the stomach controls the rate of glucose delivery to the small intestine, determining when and how fast glucose enters circulation. So this is very important. This gatekeeper function is very, very critical for predicting insulin requirements, because the moment, the glucose is seen, so the insulin has to be there around in order to metabolize, as we all know. But when gastric emptying becomes unpredictable, then what will insulin do? So insulin doesn't have a role to play much. So at times when it is available to play on the glucose, it is not there, because it is not being emptied only, the food is not there. So once it is getting glucose, then insulin is already exhausted. So hypo and hyper. So this particular trait keeps on continuing, and that is a result of, unpredictable glycemic control for each and every cases mostly. But again, mostly, if it is controlled well, then of course we have a better adherence in the later part of the cycle. Now, the pathophysiology. So as we are discussing that more core mechanism, so diabetic neuropathy is one, then pacemaker cells, very, very important. This interstitial cells of Kajal act as the stomach's natural pacemaker. So this actually generates the peristalsis, the peristaltic rhythm, which are the electrical rhythms that trigger contractions.
I'm not supposed to eat the country যখন তখন তারপর যখন এসেছিলাম আমি ওকে সেটা না বলে এসেছি। এবার আমি যখন এসেছি ও চলে যাওয়ার আগে বললাম চলে যাওয়ার
Excuse me, am I audible?
Excuse me, আমি তখন বুঝেছি ওকে বললাম
Excuse me.
Now you have to go to India. So
excuse me. So I think there is some, noise in between.
Yes, ma'am,
Yes,
you are
Anuradha,
audible.
someone
Mic is on,
uh,
maybe.
Yes. Kindly have a note to it, because that creates, like a burden on my speaking. So I'm facing a
Okay, I
difficult.
request the admin to please. Paramita Khushbu, you need to mute, huh? Okay, sorry.
Sure.
Yeah. So let us again get back. So we have a very interesting and very interesting part of this pacemaker cells playing a very important role here, where we have this stomach's natural pacemaker turning on and often, which makes the motility very and that trigger contractions, and diabetes damages this cell. So a long-term diabetes, this actually not only it affects the vagus nerve as a part of autonomic neuropathy, but at the same time it also damages this pacemaker cells. So this also disrupts motility of the gut. So this also finally it results in poor contractions, leading to delayed emptying. So the stomach cannot grind food properly or propel it onto the small intestine where it actually should be, because the peristalsis is in this flow. So if it goes abnormal, so the food has to be emptied on lesser time, and it takes a lot of time actually. So this is the pathophysiology of gastroparesis, where we actually see the normal gastric motility, which already I have discussed, and mechanisms of dysfunction in diabetes, like leading to vagus nerve damage. Then the cagal cells also are damaged. Then the smooth functioning of the muscles are dysfunctioning because of metabolic damage. And all this lead to poor neural control, impaired electrical rhythm, and finally the weak gastric contractions. And finally, all lead to the same goal, that means the pyloric dysfunction, and the pylorus fails to relax adequately, prolonged pyloric closure. So the pyloric sphincter is actually not operating well, and so that reason it results to delayed gastric emptying. And finally, the clinical consequences, I think we are all mastered to it. So the nausea, puking, early satiety, bloating, erratic blood absorption, glycemic variability, weight loss, malnutrition, electrolyte imbalance, dehydration, because often the patient is puking so much that is resulted immediately you are taking food and the patient is puking. Due to this sudden discomfort of the stomach persistently they are facing, and that results to an electrolyte imbalance. And then finally, the poor quality of living. That is most annoying, that once you are doing everything, but you are not being able to live a standard living. So this combined effect of neural, electrical, and myogenic pyloric dysfunction results, and finally that ends up into gastroparesis, and finally impaired nutrition and glycemic instability. So this is the entire thing, the gut glucose axis. The stomach controls the rate of glucose delivery, as we are already being seeing. The slow emptying, food delays in stomach, glucose rises slowly or not at all initially, as we are all understanding, because food is delayed in the stomach itself. So how will the glucose rise? So it is rising very slowly or not at all initially. And then finally, the patterns vary day to day. Glucose control becomes erratic and it is becoming unpredictable at the end. But in between, we have a sudden emptying, which actually it is like a jar. It triggers. So suddenly the food, without an indication, it empties and food finally exists. Rapid glucose spike occurs. So insulin is, by that time, insulin is totally exhausted, or maybe some portions are remained with. So that creates a total, like a khichdi in the entire glycemic control. So this is actually the fundamental reason of having a glucose unpredictable pattern or a curve. So this is the glycemic variability, the timing mismatch. So first we have an insulin injection, which actually we are discussing since a long time, resulting into hypoglycemia, and then suddenly food, sudden emptying, where we result into hyperglycemia. So this is the entire hormonal regulation of gastric emptying. We have this GLP-1 and gastric motility. Then we this glucagon-like peptide 1. This naturally slows, as we have already discussed, that which as a part of normal glucose homeostasis, it delays nutrient absorption. It is naturally it is doing. It is actually indicated. But if it is with already with gastroparesis and we are giving more GLP-1 RA, so that means like we are actually making it more to happen, the gastric emptying, it becomes more slower, sluggish. So the clinical implication is GLP-1 receptor agonist. This particular thing, as named like linaglutide, semaglutide, intentionally it is slowing down even more to it, and it is actually, this is done purposefully for obesity, for diabetes. But here in the case, it is the situation is already worse. So that medications may worsen symptoms even more. So integrated control is often seen to, happen. So hormones and the nerves work together to regulate the motility. Now, when nerve damage impairs contractions, hormonal influences become more pronounced. So this we need to remember. And these are the roles of other hormones also, along with GLP, glucagon-like peptide. We have this ghrelin, which is also very, very important part. So because this is produced mainly in the gastric fundus, and this also is the only which stimulates the appetite and gastric motility. Now, this also improves the motility, but you know what happens in gastroparesis? The fasting ghrelin may be elevated, but response to the meal is blunted. So this is a, difficult situation, which creates a trouble. And insulin also, this is kitchpit happening to insulin, that it is facilitating glucose uptake and utilization, but initially there is a mismatching in the glucose and the insulin availability. So that creates a trouble. And there are other hormones that modulate the gastric emptying, that is cholecystokinin, then peptide YY, which is also very important, then motilin hormones, which also stimulates the this migratory this particular complex and migratory motor complex. So this is also very important. And then somatostatin, which also inhibits gastric motility. So all these hormones actually are the key hormonal regulators for gastric motility and emptying. But due to this hormonal dysfunction and insulin glucose mismatch in gastroparesis, each of these hormones actually function in a derailed manner. So ultimately resulting in this insulin glucose mismatch, that becomes a key problem. And finally, the early phase, we end up in hypoglycemia risk, and in later phase, we have hyperglycemia spike. So glucose is in between, it is having a variability, which is actually very difficult to control. So everything we have to get into a steadiness, and that we later part of the presentation will understand that how actually we somehow, because it is 100%, it is very difficult to get a control over gastroparesis, very, very difficult. Even I have been discussing with the doctors, the patients, so they are not 100% absolutely all fine as before, but the symptomatically they are better, we must say. So the clinical features, recognizing the patterns, so the gastrointestinal symptoms, that is the first thing to understand, and the metabolic symptoms, that erratic glucose, as already we are discussing, and the clinical pearl to it. For diabetes is unstable despite apparent compliance, then this has to be, this is very important, then suspect gastroparesis. So once diabetes is unstable, there is an unpredictable, glycemic control, then we expect to have gastroparesis already existing, and with the symptoms even more confirming the case. So let us delve into we should always be getting into the consultation accordingly to the patient, and we should basically start with the nutritional management counseling, psychological counseling related to gastroparesis. So nutritional management of delayed gastric emptying, a clinical guide which we need to follow. So understanding the complications, first of all, very, very important, malnutrition, then electrolyte imbalance, because more of puking, more of, nauseating, the patient not eating and suddenly getting into pukes. So this results to electrolyte imbalance. And then finally, there is a psychological burden, because, every disease, to some extent, we have to have a counseling sessions done properly. And I keenly request all the dietitians here in the audience that let us not be, very, rapidly doing and discussing with the patient's difficulty. Let us have some empathy towards the patient, and let us take individual case as an individual concern and discuss them with a lot of, empathy, and psychologically testing them with so many tools we have these days, so that we actually apprehend what condition they are undergoing. So the psychological burden also should not be overruled. So this diagnostic approach we already discussed. The gold standard remains the gastric emptying study, which is very, very important to understand. We take the breath test in the laboratory, and the patient are confirmed with the gastroparesis or difficulty in gastric emptying. So we actually do it in the laboratory. So here the dietitian's role is to identify red flags, which already we should be doing it. The red flags, which are very, very important to understand: persistent nausea, early satiety, unexplained weight loss, and they are actually referral to all the evaluation leading to gastroparesis. And this is some of the diagnostic methods which we actually see. And this is a reference which I've got from my friend, which I have not much to understand. But of course, it is the scintigraphy, which I have tried to, show you here. And this is a gastric emptying process. And here there is a delayed gastric emptying. And this is a GEBT testing procedure. The patient is fasting overnight. And then the pre-meal is breath sample is taken. Then prepare a GBT test meal. And finally, the gastric emptying breath test. GBT is gastric emptying breath test. And the patient consumes the test meal. And so 10 minutes, first of all, 0 minute, then 10 minutes. We actually, it is customized from lab to lab. So they do not follow a strict protocol that 10 minutes, less than 10 minutes, not like that. So there are different protocols following in different labs. At least some of the labs vary in their protocol. And when the patient finishes the meal, they are setting a timer, and finally the samples are sent to the lab for breath analysis, and clinician interprets this test analysis report. And finally, this is the scintigraphy, how I have tried to show you. So nutrition challenges, as we are already been discussing, with food intolerance, symptomatic fear, anxiety about nausea, that abhi mujhe puking aa jayega. So it's something very difficult to understand and apprehend. Abhi mat khilaiye, mera vomiting ho jayega. So very difficult and to handle this psychological fear. And of course, the patient is malnourished, as at times there is a weight loss, there is some electrolyte imbalance. The patient is feeling challenges like heaviness, then or difficulty, heartburn, bloated. So a lot of nutritional deficit actually is seen to overrule. Now, nutritional goals, as we need to understand. The diet is both preventive and therapeutic in delayed gastric emptying. So we need to maintain adequate nutrition, stabilize glucose levels, and prevent complications further to happen. Because if persistently malnutrition stays, then we have difficulty in final managing. Because once the patient is beyond our control, then of course we really cannot help the patient with doing better. So core dietary principles, as we also would like to, put our eye. So small frequent meals. So this foundational strategy is actually very, very important. That's very, very important. And we being the dietitians or in the diet teaching students, we need to understand that, first of all, there is a strategy or a principle for every therapeutic causes we are trying to intervene with. So the foundational strategies is the most important strategy is we have to reduce the gastric burden while we have to give maximum and optimum nutrition to individual patients suffering from gastroparesis associated with diabetes. So we have to actually, we cannot compromise the nutrition, because once you see the patient coming to you with, a very malnourished look, with lowering his body weight, and the vitals are also, some way or the other deteriorating. So you need to plan the small and frequent meals, but optimizing in the nutrition. That is very important to understand, that we have to optimize the nutrition, certainly, that because we already know that the patient will not be able to, ठूस के खा नहीं सकते हैं. So once the patient cannot have that condition, so we have to plan small meals, but yet fully nutrient dense. So that small frequent 5 to 6 smaller meals daily would reduce the gastric distension and workload compared to large macro meals. So we cannot really do anything. But usually what happens for diabetes patients, we actually, once they are in insulin or in some other anti-diabetic drugs, we usually try to, give them high on fiber foods, and, like low carb, we usually give complex carbs. So these are the management we usually do it. But here we have to be very specific, because, we cannot really give the patient with a high fiber diet, because the more fiber, the more flatulence, the more bloating, and the patient will end up in puking and even delayed gastric emptying. And at times, a lot of other difficulties will happen. So here also the second concern, we have to significantly lower the fat content, because as we know that fat also delays gastric emptying. So we have to limit the fat to 40 to 50 grams daily, or even lesser to that, depending on because that is randomly I have written. But we have to actually lesser, because there is no set protocol guidelines that, okay, this person will be given to 30 grams of fat. So it depends on the body composition, body size, and everything as per the requirement. But we have to limit the fat, because visible fat, we simply need to reduce, and the protein, the invisible fats, of course, and some of the omega-3 important by essential fatty acids we need to give. But that too, very intelligently, we have to optimize the particular diet, and we have to make it minimum per meal, the patient is not bloated. Now, low fiber approach, already I have discussed, that refined grains, peeled fruits, even the fruits with the skin, that creates a huge problem. I'll discuss later on. And liquid nutrition is often, it's a boon in this particular therapy of gastroparesis. So supplement with nutritional shakes and smoothies when solid food tolerance is limited. So I have even seen meal replacement doing wonderful for this patient suffering from gastroparesis, or maybe any of the metabolic disorders. So, but that has to be, very specifically selected. We cannot go for randomly any meal, and every meal replacement will not help. Certainly we have to go through and we are, qualified enough to understand that what meal replacement we should be suggesting in consultation with the doctors, or we can consult within ourselves and the patients also. Now, these are some of the tips to minimize symptoms through nutrition, or otherwise also. The first important part is hydration. Now, the goal is like 1500 to 2400 ml per day. It can be, though it can be even more, like in this condition of so much of humidity and so much of tough time going on with so much of sweating every time. So we need to hydrate ourselves properly, and we need to make the patients even hydrate better than us, because we are not having gastroparesis, whereas the patient coming to us, they need to sip wise take water throughout the day. But at times, the water drinking becomes monotonous. So we can give tender coconut water, because usually the patient is suffering from electrolyte imbalance. So the tender coconut water, even some of the smoothies, the thin dal, stew, vegetable stew, very thin, very thin consistency vegetable stews. That's just the strained one could be some of the alternatives. But because, water often becomes very monotonous for us to consume throughout the day. So we can give alternatives, but of course we have to make ourselves certain and sure that we are taking small sips throughout the day. And liquid protein meals, replacement drinks may be very helpful for extreme bad days, because there are very bad days at times when the patient is seen to constantly puke and bloated. So many difficulties are extreme bad days. So there we can even give meal replacement, liquid protein But of course, my suggestion would be like, without giving a particular, like a gravy or particular thing, let us be very willful in substituting that particular amount which the patient still can tolerate with protein, and that too easily digestible protein, because already the patient is into malnutrition, so losing more on the protein can create a trouble. So I personally feel that if we are actually, the patient is not in a condition to eat at all, so sacrificing the gravy or some sauce with a good amount of protein, which is of course an easily acceptable protein, should be a better, in a minced form, in a mushy form, that should be given to the patient. So the dehydration can lead to higher blood sugar levels. As we all know, the concentration increases, and that leads to more sugar levels and unpredictable glycemic control, and of course increase the risk of nausea. So the portion is also very, very important. So they are not normally in a metabolic condition. So the smaller and more frequent meals, snacking, that too, I mean, the consistency is very important, reduce the stress on the stomach. So for example, already we have discussed 5 to 6 times per day, especially in the case of early satiety, we should be careful in giving the patients with the snacking or the small portions. I mean, each time we give, whatever we select, we have to be very careful on the fiber, the fat, along with the carbohydrate, harshness of the carbohydrate. Depending on the high fiber, we should never be choosing, but instead we should be getting into small portions very frequently, so that, and even like the bite size can be very, very small. So, but we should be making sure that each time the patient is given with the food, he should be in a condition to eat it whole, not that after each feeding he should be puked it, or he should be vomiting it out. So that we have to be very, very careful, because the patient will reach an early satiety, even though we are very, very, we are thinking that maybe the second or the fourth serving will not help him to puke, but immediately we end up with this hope and the patient is puking it off. So we have to be very, very meticulous in, and we cannot be over enthusiastic with the portions also, and with the number of times giving the small portions also. So at least we have to rationalize in that also, frequency also. And the texture, as already been mentioned, the mushy, it should be, like a masticated, mushy and minced form, than giving a solid, hard type of food. And it is always better. And even though the patient is, trying to eat more in the solid, we have to make the patient understand that the food is chewed well. Properly, the food has to be chewed well in the buccal cavity, so that the patient is having least minimum load while there is a delayed gastric emptying. And of course, very, very important part of the presentation, very important, I must say, because after eating, most of us do have a habit of, sleeping or maybe like lying down. So here for gastroparesis, it is like always requested to be upright in a mobile, or maybe like we can take some strands, few walks after eating. Just after eating, we should not be getting into the bed or in the lying down condition, so that the stomach even loses its motility, and the muscles of the stomach, like they do not understand that how they need to function, and they are even relaxed. So the motility can only be in a better version, provided we do not sleep or lie down just after eating the food. Maybe we are feeling tired, but still then we need to be awake, and we need to take one strand or the other. We need to mobilize, and then we can get into our normal regimen. Okay. And then the macronutrient management, already we have been discussing that the carbohydrates, protein, fat, everything we need to prioritize. But of course, the monitoring the glucose, the how much spike it can take, we have to be very, very, careful. And the protein has to be very essentially chosen. The small, easily digestible, qualitative and quantitative beneficial protein has to be made into the, plan. And fat also, it should be restrictive. Fat is very important, because fat actually lower the gastric emptying capacity. So then strategic selection, of course, we have to understand that refined carbohydrates often better digestibility, but they cannot be chosen because they are very difficult for the diabetes patients to, get into the spike. So we have to, like eliminate whole grains with intact bran, raw vegetables and salads we cannot give, legumes and beans we cannot give, because they causes with a lot of phytates and, this oxalates, they actually create a lot of bloating, anti-nutritional factors are there. So a high fiber cereals also we cannot give into the accountability. So avoiding this, that means we are left with what? we are left with only simple carbohydrates, but not really the case. We can give, without, at times we are eating, like overnight soaked oats with curd. But usually for this gastroparesis patient, we need to give it, cook it thoroughly, and we need to, cook it thoroughly, and we can give a cooked version of oats, but in a very small quantity. We can try out, because every patient behaves separately and differently than the other. But absolutely, I mean, with simple sugars and simple bread, pasta, though it is preferable as part of the regimen, it is preferable. But we should not be over enthusiastic in substituting all the simpler carbohydrates with this complex carbohydrate. But better, we should give small portions. And peeled fruits, of course, very, very important. We should not be giving anything with the skin, because the small seeds in the strawberry, or maybe pineapple with so much of skin, and then maybe cranberries, blueberries with a thin skin, that also creates problem, because that creates a problem that remains undigested, and we have this bezoils formation, which are hard, very hard, difficult stools which are there. And ultimately, that has to be, at times, if it is not removed from the GI tract, it has to be operated out, which is very painful. So don't, it's always like, don't give some scope where we have a lot of difficulty. So but still, of course, a lot amount of whole grains, raw vegetables, salads, undigestible parts of the fruit, that should not be given. So we have to be not over enthusiastic in the nutritional dealing. And then finally, the protein recommendations. So the protein is very crucial. As for every other case, it is very crucial for preventing sarcopenia and muscle catabolism, and maintaining strength during periods of inadequate intake. And there are certain priority foods, of course, liquid options are there, and supplement strategy, because in case you are not very sure that there is the adherence, the patient is maintaining with the adherence of the quality and the quantity, we can go for a supplementation. But that too, we need to be very, very, support with the documents, with all the labels we need to satisfy, and then only we can give a protein supplement powders, which can be whey concentrate or something which will not create a lot of harm to do with the digestion or metabolism. And then the key takeaways before I finally end the presentation, let us get into a key takeaways. Like, effective nutritional management requires balancing symptom control with adequate nutrient intake through the strategic planning. So as I told, the planning has to be very, very important. So the key takeaways from here, I would say, for the nutritional management would be: number one, small frequent meals to reduce gastric burden while maintaining intake. Number two, low fat and low fiber choices, optimizing digestibility and tolerance. Number three, protein preservation prevents muscle loss and maintains the strength and rigidity of our entire structure. So that has to be also kept into mind. And finally, the liquid nutrition supplements support when solid food is becoming challenging. So we have to understand that also other things we need to understand. We need to track the weight regularly. We need to nutritional status, that how to the patient regularly, that exactly how he is doing, whether the second day is better than the previous one. So those early intervention actually prevents progression to severe complications. So we need to spend some time with the patient over the phone, over visits when he comes to your clinic. So we need to be, spending some good time with him, so that because it's a real trouble when the patient is into this gastroparesis. So this is nutritional management of diabetic gastroparesis, and this understanding the gut glucose connection. This everything we have been explaining. The delayed, these are all the takeaways. The delayed gastric emptying in gastroparesis creates unpredictable glucose pattern. So this has to be, this is the main problem why gut health is important in this diabetes and this glucose connection, how it is establishing. So finally, the mismatching leads to both hyperglycemia and hypoglycemia risk, making diabetes management particularly challenging. So core management strategy, hydration protocol, we need to hydrate the patients properly. Insulin timing adjustments need to be titrated, and even when the patient is on semaglutide or linaglutide, the doctor and the dietitians need to titrate the doses when there is an escalation. So randomly the patient is feeling very happy with the weight loss and suddenly the escalation is happening. So that should not be the case, and frequent small meals every time the patient is having difficulty in eating. And this is the Indian diet adaptations like khichdi, dalia, soft curd, and buttermilk, well-cooked vegetables. So these are the recommended ones, but always sip-wise and seeing the condition, which food he or she is tolerating, that food should be stressed upon. And of course, avoid these items like raw salad, thick gravy, fried snacks, high fiber, whole grains. So this has to be avoided. And also this, again, the same thing, foods to include and avoid. Just have a quick look over it. And another concern is carbonated beverages, and of course this alcohol, then cola beverages. So this creates a lot of extra bloating, which has to be stopped during gastroparesis. And finally, the advanced nutritional support, oral supplements and enteral nutrition when the patient is into a lot of difficulty. And this lifestyle modifications, already we have discussed, that light to moderate physical activities. Even a small lifestyle changes create meaningful improvements when combined with dietary modifications. So this has to be understood, and walking or, like moderate taking a stroll, talking to individual in a field, that is not an exercise, that is an activity. So we basically need to activate our body and make our body understand that it is mobile. So a lifestyle changes creates an impactful, effect. So these are the medical management, which I'm not very mastered to it. Doctors will be better person to speak about this. But of course, prokinetic agents, then glucose monitoring, regular follow-ups, these are all very essential. And this is the case study clinical impact, where I've seen that reduced vomiting, HbA1c reduction, so 3.2 kg weight gain. So this all happens when the patient demonstrates that how structured dietary intervention actually addresses both gastroparesis symptoms and glucose variability simultaneously. So this is according to the ADA, American Dietetic Association, as you all know, and these are the different, references also I've given. So the key takeaways at the end: gut controls glucose, diet is the cornerstone, and we have to get into an individualized approach. So thank you. And once again, treat the gut, stabilize the glucose, transform the patient's life. So that is our motto. And I think that, once we do it properly, we do a justice to the patient.
Over to Anindita, ma'am. You are on mute, Anindita.
Thank you so much, Anuradha. It was a wonderful presentations. You describe a lot and very clearly. I think we will get some questions from the audience. Before getting the questions, one questions I just wanted to ask you, or you can share your opinion. What kind of nutritional deficiencies you are addressing for these patients? Kind of. So most of the patients, what are the suffering nutritional deficiencies there?
See, ma'am, thank you for the question. But I think that in my presentation, I have mentioned many a times that, so many, the patient is suffering with a nutritional status deficiency. You can well understand the patient either, he or she is into a state of malnutrition. So the electrolyte imbalance is one of the very difficult state he or she could be in. So the malnutrition, then the weight management, then the patient to be with some electrolytes and all these things. The patient is generalized with a impaired nutritional status. Right. So in any case, malnutrition is one of the very
screen, and we can give some food items from that. Okay, yes. So we will like to get some questions from the audience.
Any question in the chat box?
Are you there?
No, there are very, very excellent comments coming for Dr. Anuradha.
Anindita, this is Ipshita Chakravarti. Can I ask one question?
Yeah.
Yes, absolutely, ma'am. It will be my pleasure.
Yeah.
Anuradha, wonderful session as always, because earlier also I've listened to you and you are such a good speaker. So here I would like to add or suggest something like for gastroparesis, being a diabetic patient, I can say few medications also have a direct role on that. Because a prolonged usage of one particular medication, I don't want to quote the name here, But as practicing dietitians, we need to look into the food drug nutrient interaction as well as the dietary intervention and what needs to be given, which you have already explained, like fiber and everything you have explained. So few medications are there. Prolonged usage of those items are really detrimental in having this. It's my thoughts basically. You can throw
Absolutely,
some
ma'am.
light on that.
Absolutely. I would be very
Yes,
keen on
Ipshita.
getting a discussion personally to you and learn more from you, ma'am.
Nina ma'am
Alhamdulillah,
also there. So Nina ma'am,
Yeah.
please.
Hello.
We wanted to see you, ma'am.
Okay. Yeah. I was
Ma'am,
saying,
please ask the questions.
Ma'am,
right. It
first
is,
of all, I would like to say you something because when I started my career in Woodlands, you might not remember me, but I have
oh,
been admiring you like anything
oh,
because in
well, it's
2000,
really good to hear that, Anuradha, but your
yeah, this is the
presentation
same
was,
Anuradha. I have changed a lot, but I mean, as a BSc graduate, I started, I mean, working under your expertise. You don't certainly remember me because I was suddenly seen absconding from Woodlands one fine day, but I was under your expertise and your suggestion. So I'm very, very thankful that you have joined my session,
it's
and I'm
really
grateful to
good
the
to hear
entire
So,
team
you.
of
The
Alpha.
topic
ma'am's
was
both
such.
students are there, ma'am. I'm also your first student from my career.
Yeah, I recognize you all by your face,
Anindita, don't forget
But
me. I started my career under women, so I should not be missed.
yeah,
Yes,
definitely
ma'am.
not.
Yes, ma'am.
It's wonderful to see you all doing so well, and a very interesting topic, of course. Just wanted to know, Anuradha, because you have to give low fiber, you can't give high fiber, and a lot of fruits and vegetables raw and all that. How about the constipation? Do they have any problem with their, are they very constipated, or how does their bowels go?
Yes,
Uh,
ma'am. Constipation is
Throw
very,
some
very
light on
common. Yes, benzos are also there. Hard stool-like substances are actually being formed in the gut, which is a real concern. But the thing is that the liquid part, the fluid part, the even like every time once we maintain the hydration, and maybe we substitute with some of the other, smoothies and all this, where I mean, imbibe small portions of not really the resistant starches, maybe some of the soluble starches, soluble fibers, so that can ease up. But of course, like commercial formulas, we actually need to avoid here. But and the hard skins or the like the cellulose and hemicelluloses, those actually need to be
Yeah.
guarded. But of course, the
Restricted, yeah.
yes, the easily soluble assimilable fibers can be given, but that too depending on the tolerance of the patient. And hydration is the only key, ma'am, with the smoothies
Or
and with
maybe walking and all a bit
yes,
more for
yes.
the motility of the gut.
Yes. But a well cooked food or maybe a supplementation with it, I mean, which can be a bit, like a diluted one, that can, I have seen, ma'am, I mean, given to the patient, I've seen, ma'am, that it is not creating a lot of disturbance in real life.
Okay, thank you. So
Thank you so
very
much.
nice, all of you. All the best.
Thank you so much, ma'am.
Thank you.
I'm basically indebted to Shomindu because I never expected that you will be joining. And so with Ipshita ma'am and Shudeshna ma'am and
No,
all seniors.
I must
So,
say, Shumendo, sometimes we get this, news very late, So I just saw,
Sorry,
and then I happened to, go.
actually, it was not shared in that dietitian forum group, but it was an IPM program, so it was shared in the IPM group only.
No, but I
Okay,
must
sorry.
thank you. You always inform us, and so whenever I can, I always like to be part of it.
Okay, ma'am. Thank you so much.
Thank you.
And what I understand from Dr. Anuradha, especially the counseling part is very important. A piece of paper or diet chart is not a thing. The mindful eating will play a great role. If the patient or the individual can eat very slowly, mindfully, it can be managed. Sleep pattern, another thing is very important apart from hydration, medication, sleep pattern. There are always some answer for every medical treatment. Best possible treatments are there. There are prokinetics you have mentioned. Ishita ma'am has already
antibiotics
mentioned.
are also there. Yes.
Yes, and especially the endoscopic surgical treatments are always there. But dietitian or the diet play a very, very vital role there. So if you change the lifestyle, what actually you have covered each and everything. So we do not have any questions left to ask you. But what I find, psychologically boosting the patient, counseling is very, very important here, and especially practicing mindfulness.
And in fact, I mean, in our day-to-day practice, we actually do understand that, because all of you, most of you are dietitians, and I'm the only odd one probably, because I practice very, honestly speaking.
No, you are
But
also practicing, yeah.
Yes, but very few selective cases when I get a reference from my husband or some, I mean, senior colleague, I go and visit in the hospital or in my clinic also, I get very lesser amount of patients. But of course, I would say that you are all are pioneers in practicing, and you all must have seen the, the change when you speak to the patient properly, with a proper communication, with a proper soulful, I mean, convincing attitude. The patients are really making a difference, and a sensible, parameter can be measured through the improvement in the nutritional status of that individual patient. So that is actually, we should all be mindful, and especially to the ones who are beginning their careers as a dietitian, a message to all of them, I believe, from a bit senior than them. So to all of them, that please, I mean, practice with a lot of passion, so that you do not, I mean, get over to individual patient in hurry. So practice with a passion and talk to the patient, mindfully discuss their case, and be empathetic towards individual patient, because everybody is different.
Thank you, ma'am. Over to Anuradha, ma'am.
I think few behavioral
Anindita,
changes makes a
can I
lot
just-
difference. Yeah, ma'am. Please, ma'am.
Just sorry for interrupting, but I just wanted, on this platform to tell you all you're presenting such lovely papers. Why don't you send some for the JIDA publication, the Journal of Indian Dietetic Association? I will keep
Surely, ma'am, I'll
you
connect.
the address where you all can mail. They're very good papers and very nice talks which you are doing. I think if we, publish it also in our journal, it will help a lot of,
Yes,
students as well. And everybody, will appreciate it, I'm sure. Okay, carry on.
Sure.
Yes, yeah.
Thank you.
So I think, Anuradha, for some behavioral changes, small behavioral changes can make a big difference in the gastroparesis patient, because they cannot feel like that, okay, I am gastroparesis free today. So it cannot happen like that. So generally we can, I think I can just add little bit of the soup also. If it's a protein and the few vegetables and in the mushy forms with the liquid, it can be part of the evening snacks and something like that. And changing
absolutely.
taste is also very important, and really pathetic for them, those who are suffering for this disease. And we have to be empathetic for them and realize their actual problems, and we have to give some suggestions every time, diet modifications according to their problems, and some counseling tips. It's very important, and the feedback, whatever they're facing, and the feedback is also important for us. So today, any more questions? Can we take any more questions, Shomendu, from
So
audience?
just we have to wind up. We have running out of time, and there
Okay.
are many senior academicians.
So I just would like to request the ones who are asking me questions, you can ping me personally. I would definitely love to answer them.
Definitely,
Sure.
definitely. Thanks a lot, thanks a lot, Anuradha. It's a very helpful sessions for us, and I would like to thanks IPEN for that. We are all connected in this evening, and we all are discussing with our different topics in that way. So I would like to thanks our NEC National Executive Committee member Shangumitra ma'am, and our chapter president Dr. Mahesh Jansari sir, chapter vice president our loving Ipshita ma'am, and our chapter secretary Shudeshna ma'am. I think Shudeshna di also was there. So Shudeshna di also was there. So thank you so much, Shudeshna di, and thanks for all everyone participants to be here, and thanks a lot for today's sessions. Any questions we would like to get personally, we can ping. You can ping with us. Thanks a lot, and good night today.
And the recording will be sent to you in your mail, and if required, you ping me. You can get in WhatsApp also. Thank you.
Thank you so very much. Thank you to all. Thank you.
Thanks.